back, dear friends, at Mad Medicine. So this will be the last part of postnatal history and examination in obstetrics at the rate of Mad Medicine. So in the last lecture, we were somewhere here at menstrual history, right? So in menstrual history, as I told you, we have to ask about menarche, then about the past menstrual history and the present menstrual history. Present means within a span of 6 months before the date of conception, and anything which is further beyond that, means even earlier than that, that will be the past menstrual history. In menstrual, you have to ask about the cycle, regularity of the cycle, then what is the duration of cycle, and then the amount of bleeding, the number of pads used per day. Is it associated with clots also? Is it associated with pain, cramps, and anything like that? And then, are the period cramps so bad that the patient has to take some analgesic? So all that has to be elicited in case of menstrual history. In menstrual history, once again, you can make note of the LMP, that is last menstrual period, and also the EDD, expected date of delivery. Now coming in the past history. In the past history, we have to ask past medical, surgical, as well as blood transfusion history. In medical, you can ask the patient is having any illness, for example, hypertension, diabetes mellitus, TB, epilepsy, asthma, or jaundice, typhoid, malaria, etc. Or if the patient is on any medications for the same or for any other illness. Then number 2, the surgical history, any past surgical operation, procedures, for example, laparotomy, and also the blood transfusion history, which is very important and suggestive of number 1, anemia. And secondly, means sometimes what happens even today in today's scenario, the screening in certain places is not very stringent, and if the patient has received blood transfusion, there is still a fear of transmission of blood-borne infections like hepatitis B, hepatitis C, HIV. So blood transfusion history is an important factor. Now coming to family history. In case of family history, you have to ask again any illness in the family, especially like infectious diseases, communicable illnesses, for example TB, okay, for the contacts. Apart from that, you can take hypertension, diabetes mellitus also. Then any history of twins in the females, maternal relative like the mother or the sisters, or in the family if there are some obstetric complications that the patient's sister or mother had to go through. So that will come in the family history. Now coming to personal history, this is again very important, and no matter how much we stress, you cannot ever, personal history you can never ever miss, because it is inclusive of so many factors and we have to take it meticulously. So in this there are 3 A's and 2 B's. So A is for appetite, then addiction, then allergy. B, that is bowel, and B, that is bladder. Diet is a different thing. So first you take diet. In diet, first the type of diet, is it veg or is it non-veg? Okay, so that will come in the diet part. Then also here you can draw a table, and for any typical day ask the female what she takes from morning till evening, all the food items, all the liquids and everything, and for each item you have to write accordingly the calories in that item, that is kilocalories, and the protein content. Then for the total day, calculate the calorie intake per day for that day, right, and the protein content. Then you have to know that what is the requirement of a female. For example, you have to know if she is a sedentary worker or moderate worker or heavy worker, and also the fact that during pregnancy the nutritional requirement, the kilocalories per day, they increase by 350, and during lactation they increase by up to 600 kilocalories per day. Then calculate the this calorie deficit as well as protein deficit. Okay, so calorie deficit as well as protein deficit, and then also advise the mother that what modifications in diet, the frequency of the diet or the quality of diet she should make to make for that deficit. Okay. Then appetite, you have to ask that whether the desire to eat is not early satiety, whether it is early satiety or true decrease in the appetite because of any reason. Then addiction is very important, as we already said in the first, second trimester also, that if there is a history of smoking, any form of nicotine intake, tobacco chewing, then it can be detrimental for the development of the fetus also, and can cause IUGR, some congenital anomalies. So addiction is important. Ask the woman, motivate her to go for rehabilitation, okay, and de-addiction. Then allergy, okay, any allergy to drug or any other agents. This is all A's, and in B's, bowel and bladder. So because many a times in the third trimester, constipation is a common complaint. So if the woman is having constipation, so we have to see that a stool softener can be tried, and then bladder, that is frequency of urination during the day and during the night. So one thing it was important again. I just it reminded me about the bladder word, that in case of pregnancy, usually in the first trimester and the third trimester, the urination frequency increases normally. Okay, but if it is a case of eclampsia or pre-eclampsia, there is oliguria. So oliguria was important because in our mind it is always polyuria, polyuria, polyuria. But oliguria, it should be an important point for suspecting pre-eclampsia. Okay, so bowel bladder, sleep, you can ask, okay, disturbed sleep or normal sleep, how many hours she is sleeping, because rest is very much required in that puerperium. Okay, so that was all for that personal history. Now coming to the examination. Oh my god, examination is again so pivotal for scoring great marks. So first we have to ask about the general examination. You always have to start from this statement: my patient is well oriented to time, place and person. She is sitting comfortably or lying comfortably on the couch or examining bed and is cooperative. Now, this can vary. For example, if there is postpartum psychosis or postpartum blues, or for any other mental illness in the patient, she may be very irritable. Okay, she might not be cooperating, she might not be in a well conscious state. So, all that matters here, the first line. Then, other things what you have to mention, I have not written here because everybody knows them so well. So from head to toe, general examination from head to toe, obviously the general condition, the build, then the nourishment, the weight of the patient you can ask for. Then the height is also important because if the height is less than 145 centimeter, it is coming under the risk pregnancies. Okay. Then you can ask about the conjunctiva. When the eyes start from the lower palpebral conjunctiva for anemia. Now again, they always ask grading of anemia, and they give a lot of emphasis in gynae and ops about the grading of anemia. So one way of clinically grading anemia is grade 1, grade 2 and 3. Grade 1 can be mild, grade 2 is called moderate and grade 3 is severe. So this is only clinical examination because proper you have to do on the basis of values mild, moderate and severe. Okay, this is a clinical examination, not proper hematological or numerical based. So if the patient is only having in the mucosa, that means in the lower palpebral conjunctiva or the dorsum of the tongue or the buccal mucosa, if only mucosal involvement is there, they are looking paler. So that is grade 1. Then grade 2, along with mucosa, if the nail beds are also involved, that is grade 2. And grade 3, even palmar crease is involved. So this will be the very basic clinical grading, but you also have to know the specific values of hemoglobin for each because these keep changing. So whatever latest WHO guidelines are there, you need to know them for anemia grading. Okay. And you also need to know that when, at what levels, the blood transfusion in pregnancy is indicated at what anemia. It's usually for severe. Even for moderate, we don't go for blood transfusion because of so many hazards associated with that. We usually try to make up with oral as well as parenteral supplements. So that was about lower palpebral conjunctiva, then upper bulbar conjunctiva for Uterus. Then the face, you can see about the symmetry of the face, bilateral wrinkling is present or not, okay, for any facial palsy, etc. Then comes the tongue, is it hydrated or is it coated? And also with the tongue comes the teeth, gums and orodental hygiene. Then you can ask about in the neck, you can see the in lymphadenopathy is present. Then comes further, we can come to the hands or nails. In nails, you can see for cyanosis, for clubbing, again for pallor. Then pedal edema. Okay, so that is all in the general examination. After that comes the vitals. Okay, so never ever miss vitals. Many times we are in a hurry, we take all the head to toe examination, but we don't take the vitals recording, and then it's considered a big blunder. Okay, because vitals are very important for a woman who has just delivered a baby. So in vitals, you have to ask about the BP, the blood pressure you have to measure. Ask your department to supply you with the BP instrument. Then record the pulse. In pulse, you have to write all the characters of the pulse. The pulse, the volume, the amplitude, the regularity of the pulse, the equality on both sides, any radiofemoral delay, all the characteristics of pulse. Okay, right, like we do in medicine. Then, so BP, pulse, and respiratory rate. Also, you can write the type of respiration. Is it abdominal, thoracic, or thoraco-abdominal? And the temperature is very important because in puerperal sepsis, usually the patient is having a high grade fever. So, whether the patient is febrile or afebrile, that too you have to record. Okay. Now coming to the local examination after the vitals. Now local examination or regional examination. In this we have to do it under three heads. One is the breast examination, second will be per abdomen, and third will be the scar. So in case of breast examination, you have to do first a very quick basic examination, symmetry and size of both the breasts. Then is there any, on inspection, are there any dilated veins, the condition of skin, is there any ulceration, any abnormality in the skin, overlying skin, any dimpling like that. So that will be inspection. Then on palpation, the temperature, the tenderness, then the nipple areola complex you have to see. Sometimes you will also see the secondary areola, Montgomery tubercles may be appreciated. The colostrum will be there because usually we get second or third day PNC cases because by the second, third day they are discharged itself. So there will be some colostrum. And yes, and in nipples further, is there any like cracked nipples, retracted nipples, or any eczematous changes? Okay, so in breast examination, you have to do inspection as well as palpation. Then coming to abdomen, abdomen again, inspection, palpation. So you know very well abdomen. Any case of medicine or any case of surgery, we know so well. In inspection, there are 5-7 points. What is the shape of abdomen? Is it distended? Obviously, it won't be scaphoid here because the uterus is still not involuted. It's still at the level of umbilicus or a little below that. So abdomen, you have to do inspection. So you will say that it is local distension because usually in the upper part it will be scaphoid, but in the lower, below the umbilicus region, so you have to write in the right lower and left lower quadrant, there is a localized distension. So the shape of the abdomen, the umbilicus, is it inverted, is it everted, is it centrally paged or deviated, right? Then any scar mark, any stria. Scar mark is very important for inspection also, and later in palpation also you have to check for scar tenderness. I will come to that in palpation. And any dilated veins, all that. Okay, so basic what you do in inspection abdomen. Then in palpation, first you have to do superficial palpation, temperature, tenderness, and you have to do also the deep palpation for all the organs, liver, any hepatomegaly, splenomegaly, and renal examination, kidney. After that, you also have to now specific for the uterus. So for the uterus, you have to do with the help of the ulnar border of your hand. You have to calculate the involution. You have to calculate the fundal height with the help of measuring tape in centimeters from the level of pubic symphysis. You also have to comment upon is it normal or is it sub-involution. So for that you need to know that after the 24 hours post-delivery, the uterus starts to involute at the rate of 1.25 centimeter per day, and by 6 weeks it becomes absolutely a pelvic organ. Then they will ask you what are the causes or differential diagnosis for sub-involution, so detailed product of pregnancy, a grand multipara, uterine hypotony, twin pregnancy, polyhydramnios, etc. etc. Okay, then is there any pain upon palpation? That okay, that will come in tenderness. And then scar tenderness. So what they do, they ask you that how can you elicit scar tenderness. For example, a woman had a previous cesarean section, for example, okay, and this time she had a VBAC, that is vaginal birth after cesarean. So they will ask you for the previous cesarean section, there is a midline scar. Okay, it can be transverse, it can be vertical scar. Nowadays we usually give a transverse scar in the lower segment. So they will ask you that how will you elicit scar tenderness. So what we do, a blunder we make, for example, a woman is having a vertical scar. So we start palpating the scar and we ask the woman, are you having any pain? And we look at her expressions or any agony, right? That's wrong. Because scar tenderness does not mean the superficial skin scar. Scar tenderness means the deep underlying scar which was present on the uterine muscles and different layers of the uterus. And so the uterus is always incised in a transverse fashion. On the skin, the incision may be vertical or transverse, but for the lower segment, uterine incision is always horizontal or transverse. So you have to feel it in a transverse fashion whenever they ask you to elicit scar tenderness, and not vertically along the superficial skin suture. Okay, so scar tenderness has to be felt in the lower segment of the uterus, number one, and in a transverse fashion. So that is one point that many people don't know. So that was all abdomen examination, and in the scar, that means the local examination, you have to ask the woman to expose and try to maintain the privacy, and then you have to see for the episiotomy